Good morning. I'm Dr. Srilekha from the Department of Conservative Dentistry and Endodontics. I would like to start this session with a quote, "Believe in yourself." So today's topic for discussion is endodontic mishap. Endodontic mishap, according to Tarabinjit et al. In 1990, is a procedural accident or those unfortunate occurrences that happen during treatment, some owing to inattention to detail, others totally unpredictable. So endodontic mishaps can be classified related to access cavity preparation, instrumentation related, obturation related, and miscellaneous. We are going to discuss about two headings today, that is your access related mishaps and instrumentation related mishaps, which includes access related mishaps include treating a wrong tooth, missed canals, damage to existing restoration, access cavity perforation, and crown fracture. Instrumentation mishaps, we are going to deal today with ledge formation, cervical canal perforation, mid perforation, apical perforation, and canal blockage. And separated instrument will be dealt separately. So first is the access related, which includes treating a wrong tooth. The reason is that misdiagnosis or the diagnosis may be a wrong, or isolating or putting a rubber dam in a wrong tooth. So recognition is that realizing the mistake after rubber dam removal and persistence of symptoms. So prevention is that mistakes in diagnosis should be avoided, obtaining at least 3 good pieces of evidence supporting the diagnosis. For example, that is radiograph showing a tooth with apical lesion, lack of response to EPT, draining sinus tract leading to the tooth apex, proved radiographically with GP point inserted into the tract. So missed canal. So second one is the missed canal. So the etiology includes the lack of thorough knowledge of root canal anatomy along with its variation. Inadequate access cavity preparation can also lead to missed canal. During treatment, an instrument or a filling material may be noticed to be other than exactly centered in the root, indicating the presence of another canal. Accurate access cavity. How can you prevent is that you can prepare an accurate access cavity, use of ultrasonics and use of dyes such as methylene blue to locate the missed canals, and champagne bubble test using sodium hypochlorite. Prevention is that thorough reading of the radiographs at different, which is taken at different angulation, at least 3 different angulation, good illumination and magnification, that is the utilization of loupes and endodontic microscope, adequate access cavity preparation, and clinician should always look for additional canals in every tooth that is being treated. A well-angulated periapical radiograph with cone directed straight on mesio-oblique and disto-oblique reveals 3D morphology of the tooth. In addition to the standard radiograph and digital radiography, computerized digital radiography, hidden calcified or untreated canals are well evaluated, and use of magnifying loupes and microscope as intimated earlier. So this is a picture which is showing the intraoral camera, and then you can also use illuminator to identify the missed canals, and this is a picture of loupes and endodontic microscope. And sometimes to discover the orifice we can use Munn's discovery burrs, Muller burr and Ellenberg. And this is the example or the picture that is showing the champagne bubble test, which is utilizing the sodium hypochlorite to see with the orifice. Then the third one is the access cavity perforation mishap. So perforation is undesirable communication between the pulp space and external tooth surface. This may occur during access cavity preparation, root canals preparation, or post space preparation. So how do you recognize the perforation if it has occurred? Access cavity perforation, it is occurring above the PDL attachment, and presence of leakage will be there, and into the PDL space, periodontal ligament space, you have the presence of bleeding. Confirmation is that placing a small pile through the opening and takes a radiograph. Furcation perforation involves like perforating in the furcation area, that is in the center of the tooth. So management is that you have to immediately arrest the bleeding and place an MTA or biodentin, and then you can go for rest of the root canal treatment and finally obturate it and restore it. Prognosis good for perforation if it is identified early and it is repaired early. Perforation in the access cavity preparation can occur in the furcation region in the labial or lingual aspect, or in the distal and mesial aspect. So damage to the existing restoration is another mishap that can occur during the access cavity preparation. An existing porcelain crown presents the dentist with its own unique challenge. So prevention is clamp adjacent tooth and remove all temporary crowns if it is there, to remove existence of existing permanently cemented crown before the treatment. That will lay the way for or prevents the damage to the existing restoration. The next one is that we are going to deal with the procedural errors that occurs during cleaning and shaping, that is during your biomechanical procedure, which includes the ledge formation. The first one is the ledge formation. Ledge is created when the working length can no longer be negotiated and the original patency of the canal is completely lost. The main cause is that inadequate straight line access, inadequate irrigation or lubrication, excessive enlargement of the curved canal with the files, and packing the debris in the apical portion of the canal. Small, curved and long canals are most prone to legend. So prevention is that pre-operative radiographic evaluation for root curvature, straight line access to the canals, pre-curving the files before insertion, accurate working length, frequent recapsulation and use of lubricants, recapsulate with a file smaller than the master apical file. Each file must be worked until loose before moving to the next size. Try to bypass the ledge with the help of a smaller instrument like 8 and 10. Prognosis depends upon the amount of debris that is packed beyond the ledge. So this is a picture that is showing the ledge formation and which is bypassed. The main treatment for ledge is that you have to bypass the ledge and obturate. The second one in the mishaps that is occurring during instrumentation is zipping and elbow formation. Zipping is the transportation of the apical portion of the canal. Etiology commonly seen in the curved canals. Failure to pre-curve the files, forcing the instrument in the curved canal. Use of large stiff instrument to bore out the canal. Prevention: pre-curve the initial small size instrument. Use incremental filing technique. Use flexible files. Never rotate the instruments in the curved canal. When the file is rotated in the curved canal, the apical area, a biomechanical defect results in the formation of elbow. In this case, the apical foramen will tend to become a teardrop or elliptical and can be transported from the curve of the canal. The wide apical portion of the elliptical portion is known as zip, while the narrow portion is called as an elbow. Elbow prevents the optimal compaction in the apical foramen and obturation ends at the elbow. So this is a schematic or the picture that is showing the wider portion which is called as a zipping and the narrower portion is called as the elbow. So this is the discussion which is telling about the access cavity related mishap and the biomechanical preparation related mishap. So I would like to end the session with a quote: "The success occurs when your dreams gets bigger than your excuses." Thank you.